Welcome to Health Screen TV. I'm Dr. David Badoff. I'm a medical specialist. And the podcast today is on medical advances in weight loss management. We have a distinguished panel with us today, but perhaps a few words about weight loss before I introduce our guests. Weight loss is such a confusing area. Everyone has an opinion. Everyone knows what to do. If you just look on Instagram, it seems like all you have to do is go and get some Ozempic, you'll be right. But the reality is very different. And let me introduce our distinguished medical guests who have particular expertise in weight loss management and bariatric surgery. So the first guest, who I know quite well, is Dr. Chun Chong, who is a specialist GP practitioner with particular interest in metabolic health. And Chun actually runs a medical clinic specializing in weight loss called Medi Weight Loss. Welcome.
Thanks for having me, David. We'll be excited, interested in our discussion.
I'm sure we can provide some solutions for the weight loss for the rest of the population. We have all the answers. Our other guest is Mr. Yuan Cheng, who is a bariatric and general surgeon with extensive training and experience both in Australia and Europe. Yuan, welcome to the program.
Hi, David, and thank you for inviting me. It's a great pleasure to be here.
So let's get into it. So as I mentioned, everyone has an answer. Should I just go get Ozempic? Is it more complicated than that? But I guess the first question is weight loss. So I'm a bit overweight, so is that the problem? Are there any issues more than just the looks? Why does obesity and weight gain is important to our health and lifespan? Perhaps I'll start with Chun.
Okay, so this topic is very dear to me because obviously, apart from managing patient with metabolic health issue, obesity issue, I'm a general practitioner that manage people in general. And if you're talking about preventative health, this is what I tell my patient. If there's anything in life that you can optimize, that's going to give you the best bang for buck, and if you do have obesity issue with your metabolic health, well, that is one intervention that is going to give you the most benefit of everything else. If you haven't considered that, perhaps that's the first thing that you should look into. And we can expand into all the benefit of having optimal metabolic health and optimal weight. I'm sure Dr. Cheng would expand to even further about that. But that's just the gist of it. I think it doesn't just change the likelihood of you having issue with a joint, issue with sleep, blood pressure, diabetes control, sugar control, all the way to cancers. So the list is endless.
Yeah. Chun, so I just wanted to talk about this because there's just so many different opinions. There are so many different diets. There's intermittent fasting. There's Mediterranean diet. Everyone has an opinion. What we want to talk about, because we're medical practitioners, we want to talk about science and evidence-based medicine. Obviously, in the last probably 5 years, with the development of pharmacotherapy, that has changed our approach to all this. But perhaps if you can just give us your overview and maybe just a framework of how do you think weight loss management programs should run?
Okay, first of all, I'm the proponent of making sure that, if there's a patient that you look after, and every single patient is an individual with his individual needs. So everyone is different. There's no one size fit all. There's a lot of different services nowadays. There's direct to consumer. People go online to get a prescription for Ozempic, as you mentioned before. And I don't quite agree with that kind of let's put it that way, a marketing strategy or management of weight, direct to consumer type. I'm more of a proponent of seeing the patient as an individual, see them face to face, having a team that ranges from myself as a general practitioner to dietitians, to exercise physiologists, maybe even psychologists. And obviously, there's also bariatric surgeon involved in the management of patient with complex medical needs. Obviously, obesity is a chronic health conditions with all various different complications that we will need to manage, and everyone has got special needs that might be very different. And I think in order to manage obesity well, we do need various different strategy and a team of practitioner that can manage them with different methods of managing obesity in general.
That's a very interesting topic that you've really touched on, because I think there's a lot of patients who feel, look, I'm just going to go get a script and I'll be fine. But what you were talking about is really a multidisciplinary clinic, a multidisciplinary approach to this. Is there any evidence that this is more effective? And more importantly, is it more important in preventing you regaining weight later on? Because that's one of the big issues. Do you regain this weight later on?
Yeah, look, there's definitely evidence in that. So one of the evidence we know is all the pharmacotherapy nowadays, especially the GLP-1 receptor agonists, they work very well. They do work if you take them. You'll be able to manage to lose weight, but that's not the entire game, right? What you want to achieve is sustainable and durable weight loss. And what we know for people who takes pharmacotherapy or even weight loss surgery, they do require long-term follow-up, and we do need to ensure that they are meeting all the nutritional demand. Obviously, it will be very different for someone who is not actively losing weight. And we also understand that there's some metabolic adaptation that everyone have once they lose weight. We actually metabolize, we manage to survive on less energy, which a lot of people don't understand. And therefore, if we don't sustain what we do in general to maintain the lower weight after weight loss, well, then it doesn't work. Once we take off, the medication, for example, or we don't follow them up, they go back to poor eating habits. And there's definitely studies such as STEP 4 and, SURMOUNT 4 that, shows that people who don't take their medication, they do have a weight regain after, a period of 1 to 2 years.
Thank you. Yuan, I'll come back to you because I've got all the difficult questions for you, but I've just got all the easy one for Chun first that I want to get out of the way. So, Chun, weight loss of about 5 to 10%. Does it make any difference? Does it improve your health span? What are your thoughts on, that sort of 10% weight loss?
Yes. So look, a modest weight loss, it's reliably improved blood pressure, triglycerides, especially HDL, cholesterol, glycemic control, so sugar control. And so this can translate into fewer heart attack, fewer diabetes over time. And we understand that a modest weight loss of 10% is all we need to achieve a lot of the metabolic benefit from weight loss. Obviously, it varies in the degree of the amount of weight loss depending on what sort of end result you want to achieve for different comorbidity associated with obesity. But 10% is a good number to be aiming for someone who wants to improve their overall health?
Chun, one of the things which is confusing, I think, to patients is this concept of visceral fat. So, and as my understanding is, there's also this additional concept of a skinny fat. So you can be, have a normal BMI or even a lower BMI, but you still have a lot of visceral fat. So why is visceral fat problematic for your health?
Okay, so one of the things we know about fat is a pro-inflammatory tissue in our body. So the more fat you have, the more inflammation you have. And it is a precursor for tissue injury with inflammation. And we also know the type of fat that is worse for us is the fat that is around our central part of our body, around our abdomen, which is called the visceral fat. So fat around our organs are the worst type of fat that you can have. And it doesn't just drive systemic inflammation, you also drive fatty deposition in the liver called hepatic steatosis, and also cause atherogenic damage to your blood vessels. And so if we're talking about people who are not obese, but rather having poor metabolic health, even in the normal BMI, you can have excess deposition of visceral fat, which would mean that you are not as healthy as you think. And I mean, this is one of the measurement that we take in my clinic, in which we do measure our patient's body composition all the way from fat around the periphery to the fat around the viscera, which is the most important fat measurement to determine how good or how bad someone's metabolic health is.
Look, it's a very interesting concept. As you know, one of my passions and interests is in longevity. And one of the very few things that actually improve your longevity is what's called calorie restriction. So if you take mice and you starve them, so they just have enough, they actually live about 3 or 4 times longer. Now, they probably hungry and not very happy mice, but they do live longer. So it'll be interesting to see whether the new pharmacotherapy, apart from weight loss, can actually reverse aging and improve our longevity. Do you have any thoughts on that?
Well, I personally think that the evidence is emerging, and I got a sneaky suspicion that this is going to be a game changer in the future in terms of longevity, as well as prevention of Alzheimer's dementia, which I think time will tell. This is a very, very exciting area to be focusing on.
Yeah. So I think, as you mentioned, the pharmacotherapy has revolutionized this area. There's no doubt about that. But is pharmacotherapy, we're talking about Wegovy, Ozempic, is it for everyone? What are the potential risks? We know what the benefits are, but what are the potential risks? What are the contraindications for treatment?
So look, because the medication has been out, in 5 to 10 years. So we're talking about GLP-1 receptor agonists, which is the most popular and common weight loss medicine that a lot of people are taking. There's ongoing trial, obviously, that continues to monitor the effect and ongoing pharmacovigilance that has been run by the pharmaceutical company. One thing we know for sure is GLP-1 receptor agonists can cause loss of muscle mass and loss of bone mass, so sarcopenia and osteopenia. And therefore, this reinforces what I've mentioned previously, that we have to do this in a sort of a very multidisciplinary, medically regulated and monitored way, so that we can keep track on our patients to make sure that they are not just losing fat, they're also not losing too much muscle as a result of taking pharmacotherapy for weight loss. They are concerned about retinopathy and visual issues. Recently, there's some news about that, but time will tell. I don't think at the moment there's enough evidence to point out that to be one of the risk factor that it's definitely happening. Obviously, I'm very aware and still keep my information and abreast to all these different signals. But at this stage, all the patients that I've been treating with GLP-1 receptor agonists, apart from immediate side effects such as nausea, vomiting, diarrhea, or constipation, most have got very little side effect, and most does very well from the medication.
Now, Yuan, I promised the difficult ones for you. So I want to start really with you with two questions. So is surgery still the last resort, or should we be looking at bariatric surgery with different eyes? And also, I guess, if you can just clarify for us, what are the options for bariatric surgery? Because I'm a gastroenterologist, and I remember we started with gastric banding until probably about 5-6 years ago, which has gone out of favor. Of course, there are still gastric balloons that's been used, and I know that you do those as well as gastric sleeve and other surgical laparoscopic surgery and so on. So if you could maybe just tell us, one, when is surgery an appropriate option? And two, what are the options and pros and cons of various surgical interventions?
Okay, David. I think I'll keep it simple. For your first question, the first thing to know is there's no strict point of entry. So patients don't have to have medication before they have surgery, vice versa. So the patients can have surgery straight away if they're qualified, they're ready, they're suitable. But for people who are not ready for surgery or not qualifying for surgery, they can definitely consider medication first as well. So there's no linear progression there. But most patients who are having surgery, we would like to see they would have tried probably multiple attempts with the basic diet, exercise, because those, despite people may claim they don't work long term, but they form the fundamentals for all interventions. So we would like to see patients have good knowledge and understanding of what the healthy diet requires, what the good lifestyle when it comes to weight loss. Those are very important. And after that, whether they would like to try medication or not, for the surgeon, from our perspective, we don't really need them to try medications, but we're welcome to do it. So there's neither right or wrong when the medication comes to this picture. In the past, there has always been medical options, but the reason people don't talk too much about them is because the medications, they don't work too well. In the old days, you got the orlistat, so people have diarrhea and all. And then it's Duramine. Some people respond, but you can't take them long term. And then you got a short period of Saxenda, which is the daily injection GLP-1. And then it's quickly replaced by all these long-acting GLP-1s, weekly injections. And we still have oral options like Contrave. So the medication's always there, but it gained popularity and momentum because recent development. So you got weekly injection, and the efficacy, which is how much weight you can lose, is getting better than just 5% or 10%. So when it gets above 10%, people are more likely to use it because they see more benefit. But it doesn't mean you have to use it before surgery. So that's, I think, the first question. When it comes to the surgical option, the surgery has been there for over 60 years, so very long history. Before the ban, we actually started from open surgery. So during open surgery era, you got the gastric bypass, which is quite invasive, high mortality, high risk. And then everything started to change when we have the laparoscopic, the keyhole approach. And that brings the risk of the surgery very low. The operation becomes very more accurate, less invasive, quicker recovery. At the same time, you have better results as well. And with the band, there's a development from fixed band to adjustment band. But slowly, you're quite right, is less popular. And I think the reason it's less popular is, again, we have better options in terms of reliability and permanency of the procedure, especially with regards to sleeve gastrectomy. So the sleeve gastrectomy has been the dominant or the most preferred option for 15 years now, and it's quite a quick procedure, very quick recovery, very small risk. At the same time, it offers quite a good result, long-term weight loss result, and there's no adjustment required. So once you do the operation, that's it. So not as bad, you have to keep regular adjustments. So I think all these factors point to the popularity and acceptance of the sleeve gastrectomy. But at the same time, we still have all the other options available. So usually 80% of patients nowadays having the sleeve, and then around 10% will choose the gastric bypass. And there are various options of the gastric bypass. At least 3 or 4 procedures can be done, like with the gastric bypass. It gets a bit complicated, but usually the bypass is considered a bit more invasive operation. It's more for people with specific medical conditions, such as severe reflux or quite severe type 2 diabetes, or really super obese patients. So majority of patients don't require that degree of intervention, and they can do really well with sleeve gastrectomy. And then recent years, we've got an endoscopic approach. Probably, I think, as gastroenterologists, you will know them quite well as well. So we've got the balloon option, and also you've got the endosleeve option. So you can do a sleeve via the camera, similar, like mimicking the mechanism of the keyhole approach. And then beyond that, you've got the robotic option as well. So there are quite a range of options available for patients. But usually, my job is to make it quite simple for patients when they come to surgery. I think majority of patients would be appropriate and suitable for sleeve gastrectomy, which is a quite easy operation to understand and less risk, good outcome. And then for people who can't have sleeve or have special requirement, then would consider gastric bypass. So usually the choice is between these two.
Yuan, what is the success of bariatric surgery? Can you maybe briefly tell us how much weight does an average patient lose with a particular type of gastric sleeve or bypass? And where does the gastric balloon fit into this?
First, to define the success, I think there's no fixed criteria for that. I mean, loosely we say, if we purely from the point of how much weight one person can lose, the general acceptance is we use the definition of excess weight. So we believe the healthy range of the weight should be BMI equivalent of BMI 18 to 25. So the BMI is the body mass index. So any weight above BMI 25 is considered excess. So there's ranges from overweight and different degrees of obesity. But if patients can lose at least 50% of their excess weight, then universally that's accepted as success. But we don't usually talk about success in weight loss terms, because the opposite of success is failure. And again, we don't want to use the term failure because that's one, discouraging, two, is not scientifically accurate. From surgeons' perspective, we would like to see patients lose weight. So the ultimate aim is to improve quality of life, and also you touched on increased longevity as well. And at the same time, it's prevention of development of other medical problems like diabetes, high blood pressure, stroke, etc. But if we talk about numbers, for example, the sleeve, we say we expect people to lose around 30% of their total body weight. So if someone weighs about 100 kilos, we would like to see them losing about 30 kilos or more within the first 12 months, because that's where most weight loss happens, usually the first 12 months. The gastric bypass, which is a bit more invasive operation, and people can expect a bit more weight loss as well. So usually we say 35%. So it's not huge, not a lot more than sleeve, so probably only 5% difference. So again, if someone is 100 kilos, they potentially can expect to lose about 35 kilos. And again, there are different type of gastric bypass, so at least three types. But some particular type of bypass lose more than the others, but usually we group them together when we see the patients for the first discussion. So 30 or 35. And then putting that in perspective, when you compare that to medications, the two best options, one is the Wegovy, the other one is the Mounjaro. So Mounjaro is probably better. And then I think Cheng will be agreeing with me on this. So that's about 20%, I think, or 17 to 20%. And then the Wegovy is slightly under, it's about like around 15 to 17%. So you see the medications, it's trying to break the 20% barrier, but at the moment it's probably the best around 20. And surgery is about 30%, and the bypass is about 35% or more.
Yuan, where does the gastric balloon fit in? As I understand, it's sort of a temporizing measure. Where do you see that particular, I guess, a gastric balloon as, where does it fit within this sort of spectrum?
The gastric balloon, I think different specialists may have different opinions. So some surgeons are still offering that, and it can be done by gastroenterologists as well. Personally, I'm not a fan of gastric balloon. It's because historically the balloon actually has been there for very, very long time. So in the past it has been done before, and then it was phased out just because its limitation. One is the amount of weight loss is not ideal. It's usually less than 10%, and you're quite right. Once you remove the balloon, a very high risk for weight regain. So you have weight loss for 6 months or 12 months at best, and then the weight comes back. But it's got revived in the last few years, again, just under different brands and different type of balloon. It's really, I think, in my opinion, only suitable for people who is not appropriate or doesn't want to consider medications or doesn't want to consider surgery. It is an option, probably will be the least favorable. It's better than doing nothing, but if you do medications or surgery, then I think the balloon will be less favorable. Then one is the cost. So in Australia at the moment, the balloon is not covered by Medicare. So that means everything, putting it in, taking it out, will be all paid by the patient themselves. So the cost is actually quite significant. And then if you compare the amount of weight loss, they're probably not as good as those GLP-1 injections, and then certainly not comparable with surgery. And it's a procedure itself. It carries risk as well, right? Significant nausea, and then there's some reported case of death as well from gastric rupture. So for patients who's not considering surgery for any reason, usually I would encourage them to consider medications as well instead of balloon. But again, if they can't have medications, then I think that's where the balloon comes into the picture.
Yeah, thank you. I have the same question for the two of you, and it's really about where do you think, firstly for Chun, the advances in medical science and management of weight loss going to be in the next 5 to 10 years? And then obviously for Yuan, where do you think the surgery will be in the next 5 to 10 years? Perhaps I'll start with Chun.
Okay. Well, I think we're up for some very exciting times in terms of pharmaceutical breakthrough, especially in the weight loss and obesity space. So there's already few different medication on the phase 3 trials, such as glucagon, GLP-1 agonists, and then even triple incretin agonists, so glucagon, GLP-1 agonists, and GIP medication that are currently on trial. So if we think that Mounjaro and Wegovy are very effective currently, we may be seeing something even more effective in the near future. And this is just one of that, and there's just one of two that's currently on phase 3 trial, and there's multiple other ones, ranging from oral to monthly injection to only once injections. So it's very exciting times for development of new, even more effective and more efficacious medications. Well, one of the area that I think is going to change, not just obesity management in general, but this involves all kind of preventative health, longevity, fitness, etc., which is incorporation of big data and AI to help to guide us in terms of having treatment options that are tailored to us. And I think in the next 5 to 10 years, we'll see more of that happening. And I wouldn't be surprised if we're able to see a doctor who can run some certain AI algorithm in the future that tells us what exactly we need to do in order to optimize our health.
Chun, just a quick additional question to this. Pharmacotherapy, what happens when you stop pharmacotherapy? Is this something that do you need to be on maintenance pharmacotherapy? And what happens when you stop that? Do you regain the weight?
So the studies has told us that people or patient who's on so GLP-1 agonist or GLP-GIP combination therapy do increase in weight after they stop taking the medication. So this is what the studies has tell us. So both STEP 4 and SURMOUNT 4, which is a long-term studies, well beyond a year, looking for a patient who's been started on the medication and following them through second or third year, and also for people who stop taking the medication to see whether or not there's any difference. Well, so for participant who's on Wegovy, for example, they gain about 60% of their weight back. So they get about 2/3 of their weight back after they stop the medication in 12 months. And similar result happens as well for patient who was started on tirzepatide, which is the medical generic name for Mounjaro. Now, how that translate in terms of what we do in general, what I tend to tell my patient is, if you do see that your weight and your appetite starts to increase once you stop the medications, there's not really a huge surprise there. So what tends to happen once you take away the intervention that sort of suppresses our hunger, suppresses our body tendency to resist weight loss, is that you will see that your appetite comes back, and very likely your weight may increase once you stop the medication. It's almost like someone taking a blood pressure medication. Well, if you stop their blood pressure medication, their blood pressure tends to go up unless there's already some significant changes in the underlying cause of the condition. I mean, in obesity, for example, the condition is inherent, right? It's both your genetic predispositions, epigenetics, or obesogenic environment, and also your eating behavior and your exercise behavior. Now, the last two that I mentioned is modifiable. So you can actually increase your physical activities and eat better. Now, this is where the nuanced discussion happened, because we haven't actually have enough granularity in the data to know for sure that there's not going to be any long-lasting changes that happens in patients. Certainly, my anecdotal experience tells me that there are patients who manage to sustain a very different healthy lifestyle, a very different eating habit once they get something started in their weight loss journey to help them move to a healthier and more sustainable sort of lifestyle that promotes healthier weight. So I think the answer is somewhere in between. If you want to stop your medications, do it under medical supervision. And most people, I suspect, would need to be on long-term maintenance therapy, perhaps not at the highest dose, or perhaps not even at the dose that they manage to lose their weight, but at a certain level that manage to maintain their weight at a reasonable and healthier weight range that promotes longevity and fitness.
Great. Yuan, where do you envisage surgical therapy of obesity and bariatric surgery within the next 5 to 10 years? What is the direction? Where is it going?
I think surgery is always trying to be less invasive, more efficient, safer, at the same time offering better results for the patients. And you can see that especially in bariatric surgery for the last 60 years, and that's the trend. Every 5 to 10 years there will be almost a breakthrough, a revolution, a different new procedure that's heading towards that goal, is less invasive but safer and more effective. It's hard to say in 5 to 10 years what the actual procedure will be, whether the sleeve is still the most popular procedure by that stage. But as I think the trend indicates, we have improved from open procedure to keyhole operation, and now we have the option of endoscopic approach and robotic procedure. It's very likely that something will happen within the endoscopic realm or the robotic realm. Then you can have really minimum incisions, very small cut, and you can do everything you need through a very small cut and achieve a better and a safer result as well. And in terms of the applicability, in terms of the need for the surgery is always there, but we see the huge change in the medications just in the last few years. So probably there'll be more and more people doing the medications, and then the surgery is there to help those patients who can't use the medications for various reasons, and then the surgery is always there to help those patients.
Great. I would like to finish with two questions because we are into evidence-based medicine and we are mythbusters. So what I'd like to do is first question to Chun, what myth about weight loss or weight loss management you would like to bust?
Okay. Well, I think a lot of people has been having a lot of emphasis in body mass index as a measurement of someone's metabolic health. And it is a good guide. It is a population-based guide for us to have some sort of measure for your weight. And obviously, the easiest way to do it is by having an aggregate of your overall weight to your height. And that's what BMI is. It's a measure. BMI is considered, you consider to be in healthy weight range, as Dr. Cheng or Yuan has mentioned previously, if you're within 18 to 25. From 25 to 30, you're considered overweight, and from 30 above, you're considered obese. Now, it's a very arbitrary guide, and we've alluded previously during the discussion, you mentioned healthy fat or unhealthy skinny people. The BMI might not be such a good measure for people with significant, for example, visceral fat, and has got very little amount of muscle. They may look very normal from BMI point of view, but in a medical term, they might consider to be obese or have a very poor metabolic health. So this is one of the myths that I would like to bust. Can I do one more, David?
Absolutely.
Okay, so the second myth is about the amount of calorie that people take in. A lot of people feel that this is purely a calorie game. If I play the game well, having less calorie in, having more calorie out, I'll be all fine. I'll be losing weight, and I wouldn't need any surgery or medications. And this is purely a calorie game, right? Calorie in versus calorie out. Well, that's certainly not true. And you may be able to find initial weight loss by restricting your calorie, and you can restrict your calorie for all sorts of different diet that you can think of, from vegan diet to carnivorous diet to keto and paleo, whichever diet you can think of, they all does one thing. They try to restrict the amount of calorie that you manage to put in. That don't work in long term because our drive to eat can be altered by our body. It's the body natural drive is to conserve energy, is to allow us to save extra energy for unforeseen circumstances. Evolutionarily, individuals with weight issues tend to have the propensity to store more fat. And so even though you manage to do a short-term reduction in calorie intake, long-term wise, this doesn't work because our body tries to compensate by increasing our drive of hunger, and also at the same time reducing our metabolic rate when we lose weight. And so the actual sustainable weight loss option is not as simple as just continue to have negative caloric balance, which is true in one sense, but very wrong in terms of having a long-term successful weight loss.
Chun, this is great. Really appreciate those comments. Yuan, what myths would you like to bust?
Okay, well, I was just thinking what my answer should be while Chong is answering. So number one, I would like to say it's been one of the hardest myths or prejudice or whatever you call it in the modern society, that people regard people with obesity as lazy and not looking after themselves. I think we really want everyone to understand that obesity should be regarded as one of the chronic health disease, same as people with diabetes, same as people with high blood pressure. It shouldn't be something people judged against. It's not their laziness. It's not, there are many things at play. And I think that's the fundamental of what we do. Second thing is, as surgeon, I tend to see patients who already tried numerous ways of special diet, exercise, personal trainers, and medications, including Ozempic, including Wegovy, including Mounjaro. So I see probably a slightly selective group of patients, but the common feedback from those patients is they always regret they haven't done surgery earlier. So probably this is a bit biased, but it is true, like almost 100% of patients, if you ask them what's your biggest regret after doing surgery, is that they haven't had surgery earlier, because they do tend to regard surgery as very high risky, very invasive, potential risks. But the modern surgery has changed so much that the risk is brought down very small, and the people understand risk still stays in the old open era, so it's very outdated. I'm not encouraging people to jump on board to have surgery straight away. It does need careful consideration and discussion with their doctors. But at the same time, I don't want people to be patronized and thinking the surgery is the last resort. I think it's just need to be looked at and discussed in a very balanced view, and to really know what the risk is and what the benefit is when it comes to the individual patient.
Thank you. Colleagues, I wanted to thank you for this incredibly insightful program. I think we'll agree, I think it's been very educational. And, I think what you were able to put together is the evidence-based framework for anyone who wants to lose weight, but hopefully it will help the public to understand that this is a confusing area, but the best way to approach this is through medical science, not by watching Instagrams and influencers. Thank you for your time.
Thank you, David. Appreciate it.